Hi, welcome back. Today we are going to see the most important topic, which is highly tested in NCLEX. It is about the respiratory. Yes, it is COPD versus the asthma. COPD is chronic obstructive pulmonary disease. As it says, it is a progressive irreversible airflow limitation which includes emphysema and chronic bronchitis. Usually, it is seen in above 40 years of age who is having a history of smoking and a chronic productive cough is seen. These patients are manifested by a barrel chest, pursed lip breathing, and a decreased breath sounds, and frequent infection is most commonly present, and oxygen saturation often remains critically low. And the breath sounds are very much diminished. They have wheezing, that is a late sign, but crackles, which is due to the chronic bronchitis, is always present. The ABG pattern, what we have to monitor is the ABG manifests with respiratory acidosis, which is seen by a CO2 retention. So, this compensates over a time, and the treatment is mainly focused on bronchodilators, the steroids, and the low flow oxygen, that is 1 to 2 liter per minute. It is the most important thing to be remembered. And we have to avoid high oxygen as there is a risk of CO2 retention in such type of patients. And next, coming on to asthma, the asthma, as it says, it is a reversible airway inflammation and bronchospasm. The example of asthma is, which is mainly seen, and it is most commonly assessed in NCLEX, is often it is seen in childhood, and it is triggered by mainly the allergens or any type of exercise or a cold air. It is manifested by episodic attacks, chest tightness and a dry cough, and a severe wheezing, which is present in the breath sounds, and loud wheezing also may be present in severe type of conditions. When we see a silent chest, we should always think it is an emergency. It is because of absent airflow. The ABG pattern, what we should always see in asthma is, in early, we can see the respiratory alkalosis, and late sign of asthma, we can see respiratory acidosis. It is a bad sign. The treatment is mainly focused on short-acting bronchodilators, albuterol, and inhaled corticosteroids. Avoid triggers, and peak flow monitoring has to be done very frequently. Here, I am going to tell you about the main comparison between a COPD and an asthma. And this is a quick table we should remember in a quick revision time. The main features is, we have to differentiate between COPD and asthma is the onset. It is COPD, we have to see it is a late type of onset, and in asthma it is always seen in the childhood. And the cause is mainly smoking in COPD and allergens in case of asthma. The reversibility, COPD is often irreversible, where asthma it is a reversible type of condition. And the cough is productive in case of COPD. In asthma it is a dry cough. And oxygen, we can see it is a chronic low oxygen, and in case of asthma it is normal between the attacks. And the course, it is a progressive type of disease, that is the COPD, and episodic is the asthma. The CO2 is always retention is seen in COPD, and in asthma commonly CO2 retention is only seen in the severe cases. So this is the important comparison table between COPD and asthma. So, and the main NCLEX exam clues is, if the patient is a smoker and he is having a barrel chest, then we have to always think he is suffering from COPD. And if the child with wheezing and after a dust exposure, we have to think of asthma. And a silent chest is always indicative of emergency asthma. And a chronic CO2 retention, we should always suspect for COPD. And sudden attack triggered by an allergen, again, it is significance of asthma. This is a small memory how we can remember between these two conditions and help us in the last minute preparation. Thank you and happy learning. Good day.